We shall go on to our next speaker, Dr. Dhaivat Shah, who's the Joint Medical Director of Choitram Netralaya at Indore. And he is going to be talking to us on when and how to peel the ileum in lamellar macular hole. On to you, Doctor.
Good evening, everyone. It's very, very sweet of Dr. Chitra Madam and Dr. Jatinder to invite me to share my presentation. Rather that, I would say share my movie. So let's go through the movie called Lamellar Macular Hole, right? So whenever we see cases of lamellar macular holes, or whenever we see OCTs like these coming in our OPDs, we are very happy because we say, hey, that's a lamellar macular hole. Nothing is going to happen to that. So how did we say it's a lamellar macular hole? So there are certain characteristics. So there is a break at the level of inner retina with some splitting or schisis. There is absence of a full thickness defect, and they slowly progress over a period of time. So do we observe or do we operate these cases? So to understand this, we need to understand the classification of lamellar macular holes. So lamellar macular holes are basically classified into two categories. The good one, that is the first one, is a tractional lamellar macular hole, which has a thick ERM, intraretinal schisis, and more importantly, if you see the outer retina is absolutely clean and intact. So these are our friendly lamellar macular holes. That is how I call them, because these are good holes to have because they don't progress. In comparison to that, there is a degenerative lamellar macular hole. So how do we understand? So if we very closely look at the epiretinal membrane that is present in the degenerative macular hole, it is very thin as compared to the tractional macular hole. And if you see carefully, you can see some hyperreflective dots accumulated below the ERM. So these are postulated to be trapped nuclear cells or trapped vitreous. And this sign in a lamellar macular hole is called LHEP, or lamellar hole associated epiretinal proliferation. So this is a poor prognostic marker. Now going to the schitic area, that is the intraretinal architecture, you see there is not much schisis in these cases. And whenever we have minimal schisis in these cases, we have observed that the outer retina is really bad. The photoreceptors have nearly gone and the RP is damaged. So this is like a representative picture where you can see the lamellar hole associated epiretinal proliferation, minimal schisis, and the outer retina is completely damaged. So these are our enemies. These are poor prognostic holes, and operating such cases can cause actual deroofing and leading to a full thickness macular hole. So that is what I tend to call them. Again, to diagnose, as Dr. Jatinder mentioned, I also tend to use a lot of autofluorescence in my macular hole cases. So we know normal autofluorescence is because of lipofuscin that is accumulated in the RPE. So when we see tractional lamellar holes, the outer retina and the RPE are absolutely intact. So that is the reason the fluorescence is near normal. But when we see degenerative macular holes, the outer retina is gone and so is the RPE. So you might see an abnormal autofluorescence like we see in this case. There's a hyperreflectivity or a hyperautofluorescence. So now we know that there are two kinds of hole. One is tractional and one is degenerative. And degenerative are not to be operated. So now we come, do we operate all tractional lamellar holes or do we observe them? So what is the strategy which I use in my OPD? So I have certain criteria when it comes to lamellar macular holes. So the foremost criteria is I never tend to advise surgery on the first visit. I would rather want to see the patient again and again for the next 3 to 6 months. And I would want to see two factors. One is metamorphopsia worsening over a period of time. And second is a drop in vision. If I see these factors increasing over a period of time, then I think of a surgical plan. And very importantly, we tend to neglect cataracts or certain small defects in these cases. Removing a cataract might lead the patient to 6/6 and 6 again. So let's see some of the cases that I have seen in my OPD. So there was this 46-year-old engineer from UAE. He had come for a routine checkup and he was absolutely okay. He was 6'9" and 6, no problem with his vision, no problem with his work. But on the OCT, I saw a very fine ERM, a small dip at the level of fovea, but the outer retina is intact. So I said, okay, let's observe, but let's see you after 6 months. To my surprise, after 6 months, he had some area of schisis, but now also you see the outer retina is still intact and the patient is not complaining. So again, I asked him to see me back after 3 to 4 months, and he came after 6 months. Again, the Shices has increased a little, but more importantly, he is absolutely symptomatically free. He does not have any symptom at all. And the outer retina is intact, the ERM is the same. So again, I advised an observation. And to my surprise, after 7-8 months, when he came back, there was a formation of an early lamellar macular hole. But here also, the outer retina is intact and the patient is still not complaining. So would you really want to advise a surgery? The hole is progressing. The patient is 6, 9, and 6, and he's not complaining at all. So I personally don't tend to operate these cases, but I keep them under close follow-up. And I tell the patient that it is very important to keep on observing such things, because if it worsens over a period of time, you might need a surgery for the same. So this is again one case, a representative case where the PVD induction was actually seen over a period of 6-month interval. And now you can see nice lamellar macular hole with intraretinal Shices. Patient is still 6, 6, and 6 with this picture. So at 2 years, he came with a cataract when he was 6-12. There was an early cataract and it's 1-2. He removed the cataract, PVD got induced, and now he's stable at 6, 6, and 6 again. So these cases don't need to be operated. In contrast to that, there was this very rigid type A 52-year-old male banker, and he had severe metamorphopsia. This time he was consulting with me for the 3rd time, and the same complaints. Sir, it is metamorphopsia. I have metamorphopsia. I have vision loss. So when I saw his picture on the 3rd visit, there was an epiretinal membrane, there was a lamellar macular hole, and the outer retina was absolutely intact. So things were in good favor. And the patient was extremely keen for surgery because he understood the risks and benefits of the surgery. And the patient was absolutely ready to take the risk. So since he was extremely persistent, I advised him a vitrectomy with a peel, with a tamponade, of course. So I went ahead with the surgery, and I did not want to do extreme maneuvers in these cases. So I used a little triamcinolone and I started inducing the PVD, which I feel is the most important thing in these cases. Inducing a good PVD is extremely important. So you can see the hyaloid getting beautifully lifted up. So now the PVD was induced. I raised a small flap of the hole and I just peeled around the area of lamellar macular hole. What I did differently is I did not try to do all the fancy techniques, nor I tried to peel extensively. I did not try to do an arcade to arcade peel. I just removed the ILM and the ERM over the surface and put a good tamponade. To my fortunate surprise, he was absolutely symptom-free after 1 month. Not that his vision had improved much, but the metamorphopsia component had gone and the foveal contour was restored. So what I feel is lamellar macular hole for a retina surgeon is a very tricky situation where you want to operate.
1 minute left, doctor.
So where you want to operate these cases only when the patient is extremely willing for it, or there is extreme metamorphopsia or consequent vision loss on subsequent visits. So at the end of the day, in a nutshell, I would want to say, whenever you have a case of lamellar macular hole, it's very important to talk to the patient, understand his needs, understand his psychology, and then only advise surgery. Thank you very much.
Thank you. Thank you, Dr. Dhaivat. For a non-retina person, each of these talks have been amazing.
Thank you, ma'am.
Thank you.
Dhaivat, that you said a movie. It was a great storytelling.
Thank you. Thank you so much, sir.
Muralidhar sir, I had a question. So, like you might have started from Kelly and Wendell talking about macular hole, and so many Michael Eska talking about ILM peeling. Now we are talking about lamellar macular hole. So, do you take this metamorphopsia so seriously, or are your indications changed over the years, or it's still the same? Because it's a tricky situation, as Dr. Dhaivat mentioned.
Well, first of all, I enjoyed the talk, Dhaivat. It was a very nice talk.
Thank you.
And I actually agree with what all you said. I don't generally tend to touch lamellar macular holes unless the patient is really symptomatic with metamorphopsia. And even if there is metamorphopsia, unless it is disabling, I might not operate. If the patient is able to tolerate it, if the patient has good vision, 6/9, N6, I tend to observe them. I am very conservative. I don't think my indications have changed much over the years as far as lamellar macular hole is concerned. I am very conservative and I operate only when there is documented drop in vision and patient is having metamorphopsia and wants to, want something to be done about it.
I can't agree more, sir. Absolutely.
Saravanan sir, do you think you are happy with doing what Dhaivat did and peel it over the macula, or would you have any reasons for foveal sparing ILM peel in this kind of case?
You're muted, Saravanan, you're muted.
So I also peel across the macula. I don't do a foveal sparing peeling. But to rightly put it in perspective is that I am also not very keen on operating on lamellar macular holes, because the patient usually does not have much of a visual improvement following surgery. Even though the OCT may look a little bit better, the patient's experience itself is not that very rewarding. So I usually try to hold off till the patient is very, very symptomatic or very insistent. I am a little bit laid back as regards to LMH is concerned.
Sir, since we are not standard as a standard practice, we don't measure metamorphopsia with M charts as they are doing it. Would that add a perspective about the newer indications for managing? Because patient is complaining of metamorphopsia, we tell them to suffer. Okay, it's okay, it's okay, and keep telling him, is it fair? Is it ethical to make them suffer, or is it important to measure it?
Probably right now we are not doing that. Probably it will be prudent to measure and so make a documentation of it. But in the same complaints in routine epiretinal membrane, tractional membrane, I am very keen to operate immediately. But my only reservation is for a LHEP, lamellar hole epiretinal proliferation. In that case, I am a little bit hesitant. But for routine tractional ERMs, I am very, very aggressive. I operate even if the patient has got 6/6 vision. They complain of distortion, I immediately take it up for surgery.
Actually, can I ask something?
Yeah, please go ahead.
For Saravanan sir, like for example, of course, if there is an LHEP, as you rightly mentioned, it's a tricky situation. Sometimes if you're operating for a TRD and you have ERM, you're not planning to put an oil where you want to take off the ILM. There, if you inquire this LHEP tissue, what's the end point of peeling? Like, will you just peel it inward, leave it, or trim it?
So I peel it. So once you start going into the LHEP, you'll see the yellow color is xanthophyll discoloration.
Yes.
So I just
like
sort of stop there. I trim it till that age and then sort of pull it over the fovea to sort of bridge the gap. So my xanthophyll, visible xanthophyll pigmentation is where I mean, slightly peripheral to that, I trim it off.
Exactly. Like primary LHEP, we don't operate, but intraoperative, when you encounter it, becomes tricky. So thank you, sir.
I have a question for Dr. Dhaivat and
Yes,
the panelists,
yes,
of course. So
yeah.
the first case that you showed, when you showed the serial OCT, is that the lamellar hole eventually converted to a more degenerative type. So initially it was a very sharp split, and then later on it became more degenerative. Although the visual acuity was okay even at that level, but could we have done anything earlier, or does early surgery or early intervention in these patients help, or they are eventually going to progress to degenerative anyways and we leave it alone?
So I feel in these type of cases, the surgeon is on a seesaw, right? The patient does not have vision loss. The patient is absolutely symptomatically free. And the patient understands. And this patient was very vigilant. He was using an AMSLA, plus he was coming on routine follow-ups. He was taking a follow-up at 3 months in UAE and 6 months in India. So I personally don't tend to operate these cases on an early basis. But I tell them on the first visit itself, if this thing tends to progress, you might need surgery, mainly to reduce your metamorphopsia and to maintain whatever vision you have. So that is how I manage these cases. I am a little conservative. I'm not very aggressive.
Yeah, I think that's a very good point. No, I think that's a very good point. You should look at patient symptoms to decide.
Exactly.
Rather
So
than
not treating the OCT, rather
not treating the OCT.
So a little chair time in the OPD, I feel, can make that difference.
Yes.
Ashreya, if you have time for just a single question.
Yes, sir. Go ahead.
Maybe the panels. I was quite interested to see that Dhaivat mentioned the use of SF6 in the patient he operated. So in my own practice, I generally tend to use only air when I'm operating on a lamellar macular hole or an ERM. I never use a gas, even SF6 or C3F8. So I'm just interested to know what the other panelists do, in their practice when there is an ERM, no macular hole, no pull test macular hole, and or even a lamellar macular hole, no pull thickness macular hole. What would they use? I would just use air.
Dr. Mohammed, Leela Mohammed.
Yeah, we use air in lamellar holes.
So
just an extension of this question, that can we close the ERM under fluid only? I mean, that's another spectrum of this question.
I don't usually use any tamponade, either air or gas.
Even air? Air, do you want to use air?
No air, no gas.
Yeah, that is what an extension of this whole question.
Correct.
Yeah.
Dr. Heb, would like to know your comments if you are here.
Well, for no tear, no air. So if there is nothing underneath that doesn't make sense putting any tamponade. If it's just a lamellar, I don't think that air adds anything. It makes us feel better, but theoretically you don't. There is no communication between the subretinal space, or you don't do laser or whatever. So theoretically you don't need air even.
Very true.
thank you.